talk will be about a very important topic, which is the management of acute smoke inhalation injury.
Well, thank you so much. Starting with inhalational injury in burn patients. Starting with the definition, what could be the definition of inhalational injury in burn patients? It is a non-specific term that refers to damage to the respiratory tract, lung tissue for heat, smoke, or chemical irritants carried into the airway during inspiration. Inhalational injury, it could be either in the upper airway, in the supraglottic area, or in the subglottic area, the tracheobronchial tree, or on the parenchymal level, including a systemic toxicity. About the upper airway injury. Upper airway injury, it may be deleterious, as we can see, and it may be difficult to be managed, even by a surgical airway. The surgical airway could be very difficult to be managed, but it could be deceiving also. So this patient we have, by examination, we find that this patient could tolerate a conservative management. What's the signs to carry with conservative management in these patients? These are we all about it. That's persistent cough, hoarseness of voice, if they have soothes, or if we have hairs of the nerves that are involved, elevated carbon monoxide level, hypoxia or hypercarbia. But keep in mind that this patient will have fluid resuscitation, and this fluid resuscitation will rapidly increase the facial edema. Eventually, the patient comes like that. There is an extensive facial edema, and intubation should carry it out very early, otherwise it will be catastrophic. This is a picture from inside, from the nasopharyngeal route, about the tube, and there is an evident laryngeal edema on the arytenoid cartilages, and we can see it. This is the entrance by the fiber-optic bronchoscopy. This is from the nasopharyngeal inlet. This is to examine the airway of this patient. Among these patients, who manifest signs of smoke inhalational injury, a sizable percentage develops complete airway obstruction. Here we can see the edema of the arytenoid folds around the endotracheal tube. This edema could lead to complete airway obstruction, and there is no clinical mean to determine which patients will do so. So once you are in doubt, you have to intubate. Later on, we will proceed for the subglottic or the tracheobronchial. Pathophysiology of tracheobronchial injury. The lungs are the most innervated visceral organ in the whole body. They are innervated by sympathetic, parasympathetic, and sensory nerves. The response to sympathetic is vasoconstrictors. To parasympathetic is vasodilators together with the sensory nerves. So here we have the norepinephrine and the neuropeptide Y. This is where in the sympathetic vasoconstrictors. The sensory nerves, they release substance B, neurokinins, and calcitonin gene-related peptides. They are all vasodilators. That's marked in blue color. And the parasympathetic, of course, they release acetylcholine and vasoactive stand peptides, which are vasodilators. So vasodilators are far beyond the vasoconstrictors that are released in response to inhalational injury. What could happen? Subglottic burn injury, sensory and vasomotor nerve ending stimulation, release of the vasoactive materials that we said. This will result in increase in the bronchial blood flow, and there is a block of the hypoxic pulmonary vasoconstriction. So all in all, there is an increase in the blood perfusion, and there is an increase in the shunt flow. This will lead to bronchial mucosal edema, increase in the exudative secretions, mucus cast formations, atelectasis, pneumonia, and increase in shunting. If not treated, eventually it will lead to respiratory failure. This picture shows us that lungs are supplied by either the pulmonary route and the bronchial route. The bronchial route are affected by the extensive vasodilatation, so there is an increase in the bronchial route and eventually there is an increase in the pulmonary blood flow. Here we have the pattern that's present especially in the proximal airway. There is, under the electron microscopy, we can see the elastic fibers that runs in the proximal airway, and this is the picture from the fiber optic from inside, a real picture from the fiber optic from inside. We can see here that there is an extensive edema, as we see in the still picture and in the video. There is an extensive edema with evidence of this fibroelastic fibers in the pattern that we can see in the form of rouges. And here we can see the suits that's present inside, in addition to edema of the mucosal edema, the extensive secretions, some of the mucus casts that are present during our initial examination. Airway compliance measured by anatomic optical coherence tomography. Actually, there is a new era to correlate the severity of the inhalational injury with the compliance of the proximal airway. They measure the compliance of the proximal airway by a device. This device is called the optical coherence tomography. It's like the technology of IVUS, the intravascular ultrasound for the coronary patients. That's to check for the wall, for the possibility of stenting or balloon dilatation or something like that. This is the same technology that they are using to measure actually the compliance of the proximal airway, reflecting severity of inhalational injury. Okay, this is the same. So it looks that compliance is hounding the burn patients all the time regarding the fluid creep, the abdominal compartmental syndrome, the lung tissue, decreased compliance and respiratory failure, and proximal airway compliance. Grading of inhalational injury. Actually, we know that we have a 0, grade 0, there is no injury. Grade 1, it is mild, and we have grade 2, it is 3, and it is graded also to 2, 3, and 4. And there is another grading, that's grade 1, 0, 1, 2, 3. This is mild, moderate, and severe. Actually, there are gray zones between these grades, and it is not definite while you are examining the patient with the fiber optic bronchoscopy. Here we have, this is the control, and this is the grade 1, this is the grade 2, grade 3 with ulcers. And here in the video, we can see that we are proceeding. While we are proceeding, we have the lesser grades. We have the greater grades above. As we can see, we have blisters and we have ulcers. And while we are advancing, we will see a mild granulation tissue, and there is a mild edema of the bifurcations of the tracheobronchial tree. As we are advancing one on one, we will see just the hyperemia of the grade 1. But it needs an expert eye to differentiate between the different grades of inhalational injury. Actually, this is a patient, a real patient from our unit. Patient presented to us, she was 25 years old, presented to us with a 38% total burn surface area with a full face, full thickness burn, and severe inhalational injury post-suicidal attempt. Actually, this was the first fiber optic bronchoscopy examination for this patient, and as we are advancing, we can see that we have an extreme pallor of the mucosa, and there is an extensive suits all through as we pass inside up to the 4th or the 5th generation as far as we can. We have this this picture all the time, all through our examination. But there is no hyperemia. So this patient couldn't grade it for grade 1 inhalational injury. Actually, the other video is after just we need some wash of this layer that's present on the surface, and this is a jelly-like material with the suits. After we wash it, we found that we have some sort of hyperemia. That was immediate, just after an extensive wash of this carbonaceous material. So we have a grade 1 inhalation injury just after wash. The third one is the follow-up of the patient. This was on the 3rd day. And we find that we have grade 3 inhalational injury. So the first examination is not conclusive, and these gradings they have grade zones. We cannot depend on these gradings all the time. Actually, there is a new era to avoid this grade zones. They said that they have a transfer learning based bronchoscopy image. The transfer learning, it depends on the artificial intelligence. So they supply the computer with multiple pictures of the fiber optic bronchoscopy examination of inhalational injury patients, and they supply the face of these pictures. Later on, this picture, according to the AI, can provide us that this picture will carry this outcome. So that's what's called the transfer learning based bronchoscopy. Okay, about the therapeutic fiber optic bronchoscopy, we have, you can adjust the endotracheal tube. This is the mucus casts, mucus plugs, and you can remove these mucus cast plugs. As we can see, there is a multiple densities, there is a multiple colors, there is a multiple sizes of this plugs. Early suit removal, because these suits also, they are heat retainers. So if they are retained inside the airway, so they make more injury. In addition to the antibiotic formation, anticoagulant formation. We are left with the parenchymatous lung injury. Parenchymatous lung injury, it is either a complication of the tracheobronchial with respiratory failure, as we said, or a systemic toxicity. Mostly, we know the carbon monoxide and the cyanide. Okay, regarding the carbon monoxide, this is the carbon monoxide level. The allowable level is about 3% in non-smokers, 10% for smokers, and we have the critical point of the level of carbon monoxide is 40 to 50%. This is the point where the patient will develop some sort of respiratory failure and start with metabolic acidosis and the whole body shutdown. This is the maximum that can measure the carbon monoxide now, just as a finger stick. Of course, the initial management, it is if you are in doubt for carbon monoxide, you have to apply for a high flow oxygen. Okay? And you have to remove from the scene to take a thorough examination, a thorough history about if the patient has lost consciousness inside the scene or something like that. This will be more liable for carbon monoxide poisoning. The material, the environment, if the environment carries some sort of natural resources like wood or rubber or something like that, this is carbon monoxide. If synthetic, that will be more towards cyanide. Okay? And if we have some sort of a cyanide poisoning, so cyanide, we have to proceed for the hydroxycopolamine or the cyanokit, the use of the cyanokit infusion or something like that. I will not go through this because this is a very sophisticated, of course. Okay, the laboratory findings, the most common that we depend on, a resistant acidosis, a resistant high anion gap acidosis, of course. And don't depend on oxygen saturation because it is deceiving in both cases, in carbon monoxide and in cyanide poisoning. Nutshells or a take-home message. Once in doubt, go for intubation. Once in doubt, use high oxygen flow therapy. Bronchial lavage, negative balance, protective strategy is an evidence A. Heparin, flumacy or N-acetylcysteine antibiotic nebulizer is an evidence B in the management. Steroids is an evidence C, and be ahead of your patient all the time. Otherwise, you will lose him. Thank you so much.